thank you guys so much for joining us tonight. It's really exciting for us because normally when we do a mashup, I teach it with somebody who's across the country with Josh, and Josh is doing Jewish things tonight. So Megan and I are going to be doing the mashup tonight, and it's awesome because not only do we get to do this together, but we get to work side by side in our practice together every day. So happy to be doing this. We've done one other one. We did the intro one together a long time ago. So really excited to be together doing this. And we used to do an intro course. We used to do a mastering course. And now we've sort of hybridized that. And we have what we call the mashup. So this is a little bit of beginner stuff, but also some more advanced things, because we find that people that jump on these webinars, some people don't have the units and they're investigating and they want to learn more, or they've maybe tried it at a trade show, or they've used it at a friend's practice, and other people are using it and they're just having some pain points and they're having some struggles. So we try to cover both of those within the hour. Like I said, I'm in Bynum, and I practice with my husband, Matt Bynum. We went to dental school together with Slim Pickens, and I was like, need to find somebody here that's not going to drain my bank account, that's going to add to it. I'm not sure that really happened, but we've been practicing together for 30 years. We just had our 30th class reunion. I should probably update those photos and put some class photos in there. We just completely smattered our livers 2 weeks ago in Iowa City, celebrating our class reunion there. So like I said, husband's a general dentist. He just flew into Vegas tonight. He's at Dentsply Sirona World doing geeky grown-up dental things. And I don't want to steal the thunder. Megan's going to tell you about her husband later, so I'll be quiet about that. We have 3 kids, 3 boys. We're about to have 2 ladies in the family. Matthew, our oldest, is about to marry Maddie on the far left. Maddie is not the fish. Maddie is the beautiful dark-headed woman in the bottom left corner, and they are getting married in April in Sicily. And Luke, the middle child, and in the middle of the screen, is marrying Faith in May. So we have 2 weddings, 3 weeks apart, April and May. And then John over here is, he's a senior in college and has been dating. All these boys have been with all these ladies for 7 years each. So it's very easy for me to keep track of. So very, very proud of this, very proud of all the butt whippings and promises we kept to them about getting in trouble when they were doing things wrong. And they've grown into quite amazing young men who have found amazing young women.
And then I am Megan Charowski. Went to dental school at MUSC in Charleston, and I am about to celebrate my 11th wedding anniversary. So we just took a fun anniversary/birthday trip for my husband to Universal Studios. Just got back from that. And he is a general dentist, so we met in dental school. I followed him across the country being a general dentist and hated it for the first 3 months of my life, and became a general dentist in pediatrics for 3 years, and then went back to residency at Memphis, University of Tennessee. And now we have 3 little babies. We broke the 3-boy curse. So we had 2 boys. There's a 3-boy curse at Holly Tree here that has now been broken by little Poppy on the right side. And we have a wave of girls coming through this office right now. So I have a 4, almost 5-year-old, a 2.5-year-old, and an 11-month-old now.
And she would like to do these webinars every night so her husband Tomek can master.
I went from work at 5 to making dinner, bath time, putting one to bed, to racing back to the office to be on this. So thank you guys. I got 1 to bed. 2 are still crazy.
Speaking of crazy, this is our team. It is in constant flux. We have people coming and going all the time. We are 5 doctors strong here in our practice. We believe very strongly in culture. We just don't get great by doing great dentistry. We get great by pouring into people and making them better in their personal and professional lives. And Megan and I really take a lot of pride in that. So you may know us from teaching these webinars, but you may also know us because we really pour into lots of people, dentists, and practices to make them better and stronger so they can take better care of kids. And this is something we do every year. We take our team away for 3 full days and we make it all about them and just have lots of fun and seizures. Obviously we have seizures. That's what's going on here. The more I look at this picture, I'm like, wow, that's a lot going on right there.
It's a team full of fun.
All right, well, let's get started here. Chris or Jordan, if you can kick us off. We'd really like to, I already told you we're going to do like a mashup. We're going to talk some baby steps and then some mastering things as well. But we'd really like to get to read the room first. So if everyone can participate.
Yeah, just three quick questions, everybody. Just kind of like Ann said, read the room, see what everybody's using, not using, comfortable with, not comfortable with. It does give Ann and Megan a good barometer of how to tailor what they're going to talk about this evening. So if you wouldn't mind just taking a few minutes answering those 3 questions. And once everybody answers, we'll kind of quickly go through the results and share that with everybody. So looks like most are using the sew-in over the sleeper one with a very close second of not a lot of current users yet. So we still have people brand new not using the devices yet. That's great. Most don't own the device, so they're not using it exclusively, but we do have a larger percentage using it on all patients. That's great to hear. And majority of the room is not sure on the delivery method preference. So we'll cover that this evening, cruise versus drive. Between the two, it looks like cruise is preferred by the people who are using the devices, but it does look like most are not. So that's a good opportunity there for us to kind of cover some of the basics, Ann and Megan, and then get into some of the deeper dive stuff.
Sounds good.
Thanks, everybody.
I'm getting rid of the poll. All right, so back to the mashup. We're also going to incorporate some pearls as we go along here. We've got 3 practice pearls that we're going to sort of just merge into this webinar tonight. So just sort of pay attention to those. Those are things that we do inside of our practices. And we just want to start by telling you that at the end of the spectrum, you see the sew-in and the Sleeper 1.5 that we're going to talk about tonight that came out in 2023. If you look to the right of that line is going to keep going and going and going. NuSmile is going to continue to pour into pediatric dentists specifically to make us better. And we take everything back to our patients. Everything we do, our why is taking care of our patients. So if you look to the left of that line of 2023, look at all the great things that NuSmile has afforded us as pediatric dentists that we can pass on and do exceptional care with our patients. I just did a lunch and learn with a general dental office today, 2 dentists, 11 team members, and they were asking me what to use they're a very crunchy, holistic practice, and they asked what we used for pulpotomies, and I was like, MDA, Neoputty, like that's what all pediatric dentists use. Like they didn't even know about it. So hopefully, NuSmile, you will be getting a new customer after that lunch and learn today. So again, just a huge shout out to NuSmile. They really make they make
our lives easier.
Yeah, and just progressive. I just think of the word progressive. Like so much has changed in my 30 years, and just so thankful for Diane and the vision that she set out when she started this company. So what is intraosseous anesthesia? It's a lot. It's 2 big, long words that I obviously slept through that day or that course in dental school because I really don't remember much about it. I don't remember us doing it or practicing it. I think it was more like in theory. Did you give intraosseous at all? See, so even, new baby doctors, they weren't doing it either. But I had to kind of break it down for myself into bone injecting. That is what those big words mean at the top. You're just using the needle and you're putting it straight into the bone and injecting a solution. That's all these big words mean. Because when I went to the first bourbon and baby teeth and Dr. Andrew Prynne was giving a lecture on this, I wasn't even planning to go to the lecture. I was walking around the corner at 10:30 in the morning to go on a bourbon tour. And I got a strong arm to go into this lecture. And I was like, I don't even know, like, why would I need to do this? Well, I just don't even know what it is. Like, we didn't learn much about it. So I didn't think it was something we needed to know.
But this has been around for a long time. So coming back from old French literature, the idea of intraosseous anesthesia has been around since 1906. This translated says the easiest way and the most absolute way to get numb would be going through the bone to the source, to that nerve, to the pulp of that tooth.
And this is what it looks like now. I mean, prior to 2023, everything looked like that on the left side of the screen. I mean, syringes just haven't really changed much. But now they look completely different. They're streamlined, they're cleansable, they're fancy. I mean, they're basically computers.
How many of our patients have seen a syringe and tense up, whether they're adults or kids, and coming at them with this nice, sleek design is really a game changer.
So this is what they look like. And we actually, since we're not doing this from our homes tonight, we actually are sitting in our practice. We have them here. So we're going to maybe do a little vena situation here tonight. So this is what they look like. You want to talk about the sew-in first?
This is the sew-in. It is a little more portable because it is wireless. So if you are maybe a single doctor working out of multiple operatories, this might be the ideal for you. All you have to do is pick up your device, pick up your pedal, move from operatory to operatory. It has a little bit more bells and whistles in the actual device center. So it is a tiny bit heavier than the Sleeper 1.5, but it has 2 speed settings for your delivery. And this is that longer little local container. Very minute detail, but it will come into play later in our discussion.
And I'm holding the Sleeper 1.5. The Sleeper 1.5 obviously has the wire on it. It does plug into the wall. That is a little tricky. I do get very nervous about someone's knee grabbing it or the cart grabbing it or a patient grabbing it. But we have 3 of the sew-ins in our treatment rooms, and we have a Sleeper 1.5, and they live in each of our treatment rooms. So 3 rooms have the sew-in. Treatment room 4 has this in it, and I feel like we both feel the same. Like, I don't care which room I go into to do op. I'm fully comfortable using both of these devices. This is a little bit less expensive. We are going to talk price later on today. We're not going to just hook you and leave you. So we will talk about that later. We'll let Jordan dive into that. This is dummy proof. I feel like this is, we really recommend this in residency programs so that the other one is a little bit more complicated. If there's a lot of hands on people touching it, it can like mess up the settings very quickly. So this is more like dummy proof. And like Megan was saying, the containers that hold that hold the carpal vein aesthetic are a little bit different. So what we've done is all of our steri-techs and assistants know that the containers that go on the Sleeper 1.5, we put a little purple ring on there, rubber ring on there, so that we know that, hey, after these are sterilized, they go into treatment 4. All right, first pearl. That was really the first pearl. If you have the device, that's a pearl right there. All right, first pearl. This is what we do when we are hiring and onboarding team members in our practice.
So we are matching team members, new team members with our OGs in the office. We just recently started initiating a personality test to see which original team member they would match well with, so that we are making sure they're not feeling intimidated. So that is not on here, but that's another little pearl, that they're getting the training they want and they're actually hearing the training in a good way. But we check in with these new trainees. We have clinical leads and administrative leads, and we have what is called a 30-60-90 checklist. So when they're moving from trainer to trainer, our OG to another OG, they can say, okay, this person has mastered this list. They're not so much great with it. Let's touch back on the space. Or they're really struggling. Let's push a lot more so they can get adequate in this and move on. So these are 3 little examples of our 30-60-90. We never want to let somebody free in our office if we haven't given them the tools to succeed. So when do you feel like you're the biggest failure is if you just got thrown to the wolves. So we want to make sure that we have trained and educated and poured into these new team members of ours, that they feel empowered and ready to take on and love on our patients like we do.
All right, so back to these devices. The benefits that just said, where we go. What benefits do these provide to the patient? We're going to talk about the benefits to the patient and then the benefits to us as the doctors. Let's talk about the patient first. No one's eating their face. This is the best thing ever. When I was talking about these devices today at this lunch and learn that we did, and they honestly didn't believe me. I was like, bro, I will send you the stuff. Like he couldn't even get it through his head.
To our office.
Yeah, just watch these kids, right? Because this is the worst, right? Like Dr. Megan was saying, she goes home at 5 o'clock. She's got 3 kids she's got to feed and go through book bags and do all the, put on her mom hat for the night. No one wants a call at 5:30 that, this kid's allergic to Novocaine and has this situation going on. So this is gone. We've been using these devices like for 2 years, like we said. No one is chewing up their lips. We're not getting these phone calls where our assistants aren't being bothered. No one's calling the emergency line. And kids aren't hurting, which is super awesome.
Especially for your special needs patients, those ones that can't maybe comprehend the feeling of the numbness and what's going on in their mouth. The worst is when they're sitting up from getting off of that nitrous oxide and being like, where'd my face go? So very compassionate to those type of patients.
All right, the benefit to the dentist, the patient is numb immediately. There's no more, if you have we don't have parents in the room very often, but if the parents in the room, you got to sit there and like BS and make small talk for 5 to 10 minutes while the kid's getting numb or fake to go see I don't know what you do when
get out of the awkward situation.
Get out of the awkward situation and leave the operatory. But now you can't, if you do have recalls to go check, of course you can go check them. Your patient will stay numb. But the nice part is you literally put these devices down and you pick up your forcep or your elevator or your handpiece or whatever, and you go to work. So think about it from a standpoint of business, right? So we schedule 30-minute ops, and ops done in half that time, most of the time. And now you can now help more patients.
So this benefit is less injections. It is you can go in one spot, we'll talk about the perfusion of it, but 2 teeth forward, 2 teeth back on the maxillary, or 2 teeth forward, 1 tooth back on the mandible. On these lower anteriors, if you're looking at taking out N through Q, you might have done traditionally 2 to 3 injections, but you might give just 1 with the Soin or the Sleeper One.
And if I was doing that, I would not only give 1 or 2 injections, I'd be like infiltrating around all that skin and
go into the
label, bleeding. Yeah.
So these are very gentle. We're going to talk about the 2 stages of this to make it the most pain-free delivery, but it is mastering the phase 1, the stage 1, and then that stage 2. Feeling pain versus pressure. Sometimes if you're in a little bit wrong of that anatomical position, they might feel a little bit pressure. You're going to learn about that as you use the device more. Maybe you reorient, you pull out a little bit so that they're not feeling pressure of that anesthetic delivery. You're not having to go do a supplemental on the palatal. One time she said she'd rather eat fire ants than give a palatal injection, because who likes to give that pain on the palatal? Nobody does. So if you are injecting from that buccal, it does go and gets all the way that diffusion to that palatal tissue. We already talked about this, but no collateral numbness, no lips being numb, no cheeks being chewed up. You can get your patient out of the chair and say, hey, you can go drive through the drive-through, get them lunch, and send them back to school. Being able to maximize more treatment options. So doing bilateral mandible because you don't have that fully numb lip. Adding in more quadrants because you're getting that initial anesthetic numbness right away. You're able to maximize the quadrants that you're able to do. That's that immediate action, getting right to work. And in turn with that, you're not having this kid sit there wondering about what's going to come next. When are they going to do another jab? You have better behavior management because you're in the chair the less time having them worry about the anxiety of what's to come.
Well, and like you said earlier, I mean, sometimes kids are good for the initial injection, but then when they start to feel their lip go numb or their tongue go numb, that's when you lose them.
They can't comprehend that feeling. Less stress to your patient and less stress to you. That is the best. And then again, no post-operative side effects. When you're getting to learn to use this device, you might have a little bit more torn up tissue, a little more angriness in the area because you're learning where you want to inject and where you want to drop into that bone. But as you master it, you're going to have not those side effects. And then adding in more quads, being able to add in same day treatment because your 30-minute op finished in 10 minutes, maximize your business. We'll talk about this in a little bit, but if you're not like us, where we got our whole city involved in buying the sew-in, you could set yourself away apart from the businesses around you. I think 90% of the pediatric offices up here have the sew-in or the sleeper one, so we can't really say, hey, come to us. But if you're one in the area or a pediatric dentist that's just set up shop, this could change your practice image. This is where I want to talk about the hidden benefits to you as the dentist. Because you get numb immediately on your patient, that can equal your patient's not sitting there. They're not having to marinate and get numb. You don't have to change or remove your gloves. How many people had been affected by the COVID glove increase? Because we have. Gloves skyrocketed. Patients are not sitting there on nitrous while they're marinating. They're not sitting there breathing in your most expensive air that you have purchased for your office. Even if you turn down their nitrous, oxygen bottled up in that system is still very expensive. You're not paying your assistants to sit there and watch them or talk to the parent there. That is something when you're done with the op, your patient or your assistant can go help restock, help see another patient early, help do other things around the office and not just be sitting there. Able to maximize your schedule, adding in those same day treatments, not having to have a parent miss more work, miss more school, creating that good relationship with your parents and patients.
And this is what we talked about, basically just showing that, because we're injecting into the apex of the tooth, hitting the nerve, we don't have all this lip numbness going on and we're not worried about this happening anymore. This is just basically telling you when Josh does this, he does this slide when he does it and he says, typical men are going to buy these devices, unpack them, have a problem, say it's not working, complain, or tell their assistant to read it and figure it out. And that is not what Chris is laughing because he knows it happens, but that is not that's not what we recommend. We recommend that everybody, the thing that NuSmile has done is they've made it so easy, such a seamless path to getting trained on these devices, starting with these webinars, pouring into you guys before you even have the devices. But once you get the device, you need to read the manual, you need to watch the videos, you need to call Jordan and Aaron, wherever you live, and they're going to, they will take you from opening the box to using it on the very first patient. And any thing that you have, any troubleshooting going on in between, we're all here for you, but they're definitely there for you to help out.
And there's so many times I've actually saved our manual on my phone because I don't go digging through the random drawers in our office, but because we have so many sew-ins, our settings get messed up, and I like it in Drive and other people like it in Cruise, and I will move it back. And sometimes I just need a refresher on our manual to get back to those settings. So it's a great little bookmark to have on your cell phone when you need to go back and refer to these IFUs.
All right, so let's just talk about how the device works. Let's get right to it. When you are giving a traditional injection, you're going into tissue. You are relying on what you know about dental anatomy, and you're hoping that anesthetic the epinephrine is going to help hold it in place, and it's going to diffuse through tissue and diffuse through bone and get to the nerve of the teeth that you're wanting to work on. That is what we're all hoping for. And it's also dependent on the cadence that we deliver it. And we think we're delivering it in a steady cadence, but we're probably not. So when we are off the cadence and we're pushing more acidic fluid into making a bolus in the tissue, that hurts. That injecting something acidic hurts, and we are completely bypassing it by using these devices. This is just showing you that if you use, depending on what concentration you use, how far the spread can go of the anesthetic.
So if you're using that 1 to 100,000, it is going to keep it more contained, more closer to those teeth at the target. So that papilla, you might get one tooth back, one tooth forward. You would probably have to deliver a larger volume to get those 2 teeth forward or even more. The gold standard is the 1 to 200,000 epinephrine, so that you do get that 1 tooth back, 2 teeth forward on the mandible. The diffusion flows through the blood vessel flow. And so that's what I was just kind of saying. It's 2 teeth forward, 2 teeth back on the maxilla, 2 teeth forward, 1 tooth back on the mandible. And that's just the blood flow is taking that anesthetic and distributing it once you're in that bone.
And granted, this model right here is adult teeth, and all we know about growth and development, right? Like, let's say it's a 4-year-old kid. Their bone is a lot more porous, so you probably don't need as much anesthetic, and it's probably going to travel a further distance because it can go through the holes better.
So I say 2-stage, but it's really 3-stage. The first stage is when you're getting that papilla numb, you're getting that initial mucosa numb. The second is reorienting your device and getting that manual bone penetration before the third step is stepping on your pedal and delivering that anesthetic. So this papilla would be on, we got our pedals with us too. Right here in the center, this is your drop by drop. So that is your phase 1 of this delivery. The actual anesthetic delivery is on this big paddle, big line here. If your foot is on both of these pedals, it will default to that drop by drop. So make sure that actually, if you're wanting to do the full anesthetic delivery, you are moving that foot down here, because you can lay on both of these pedals and be only giving that drop by drop.
So these are just some examples of showing what Megan's talking about, that stage 1 injection. You're just going to lay the needle ever so slightly. The D needs to point out. I think we're going to talk about that a little bit later, but based on the way the needle is designed and to orient it properly, can't talk, you want the D pointing out. So, and you can see, I kind of want to show that again. I want you to see that these are 9mm small gauge needles. This needle is going to flex as we're putting it here into the papilla. And then we're stepping on that inner part of the pedal. And we're going, 5 seconds, 6 seconds. We're just going enough until that tissue starts to blanch. And this will be the second stage. This is the same kid, it's just the other side of the mouth. It was just easier to record on this side. And this is what Megan was talking about. You're going to reorient the needle and you're going in a completely separate plane. I'm going until I have positive pressure with bone. And then I'm twisting and tugging. I'm pulling back to make sure that it is snug in the bone. I can still see part of that needle at the hub. And now I feel good. Now I'm ready to deliver. So we like to have a little bit of that needle still exposed so that we're not burying it to the hub, just in case we would have a needle separation. Has not happened, but...
You're only going to get a needle separation. We get this question all the time. If you're overusing that needle, or you get a huge flexure and then you try and enter again. So if you do, as you're learning, you're going to get bendings of the needle. Pull out, change the tip, get a new one. It's always going to be sharper with a new needle tip, so spend the extra couple cents and try again. But if you are getting that big flexure, you're bending it at the hub just slightly. It might not be bent and broken, but you're going to be pushing the limit. So go ahead and change that. But like she said, you'd rather be broken in an osseous region, so your needle's not floating around somewhere. I have personally pushed the limits myself to just test it out, and all I do is pick up the hemostats, pull it on up. As long as you're never going to lose that needle if you're still appropriately penetrating it to its depth.
This is another example. This is Dr. Nash, another amazing doctor in our practice. And he's doing phase two.
So the D only needs to face out for that phase one. Does not need to be oriented towards the cheek or the lip for that phase two. It just happens to be that in this video. This is showing 2 little dots of resistance. We'll talk about the resistance buttons here on the sewing shortly. Pearl number 2. This is what we started doing. We got this from Josh when we implemented the sew-in, because we realized, hey, we're using a lot less time than we initially did. It is a tedious process that requires all team members being involved if you have a larger office, because you're wanting to see what time were they scheduled, what time were they actually arrived, how long did it take to seat them, how long was your actual procedure, and you're being able to nitpick and see where the growth is left in your office, because you just might be thinking, I'm fine, we're maximizing everything, but is it really that they sat in the chair for 5 minutes with topical in their mouth before they called for you? So you might be finding some blind spots in your practice once you do this like tedious little work. And then break down your procedures a little bit more. How long does it take for you to do a quadrant of MODOs? How long does it take for your assistant to place 4 sealants? So you're able to do more what we call perfect day scheduling and be able to maximize that schedule for you. All right, tips for this is going lateral to the midline. What that means is that triangle for the papilla, you do not want to start right at that center of the triangle, because when you advance your needle for that phase one, you're now at that thinner part of that triangle. So you want to come all the way to that first lateral side so that when you do advance it, you're right in the middle of that triangle. And the biggest tip that I ever received was from Dr. Prin, that what you first want to do is let that needle flex on the tissue. So you're getting some of that flexure, you know you're making contact with that tissue before slowly advancing it. And this phase one for the sew-in and the sleeper one, you're barely advancing that needle because of how the bevel and the needle design is. As long as that D is facing outwards away from the tissue, you just barely need to get that needle under the skin or under the papilla before administering that phase one. You do not want to jab. Don't advance too far. If you're getting to that periosteum, that's when you're going to get that reaction from your patient. That's when their pain fibers are activated.
And I'd also tell you to step on that pedal right before you start to make contact with that tissue so the anesthetic can start to flow as you pierce the skin. All right, let's talk about the blinking lights that Megan referred to. So on the Sleeper 1.5, you can, the light is, why is it not on?
It was sleeping.
Yes. So blue light tells you that you are ready to give an intraosseous injection. Pink would tell you you can use it to give a PDL or interligamental. And then orange is if you want to give a block, which I don't know why you would ever give a block. But you can give infiltrations. These, you do not, if you don't have bone to give an intraosseous injection into and you need to do just, let's say you've got some coronal remnants and you just need to pick those out of there and you want to just give some infiltrations, don't get your traditional syringe. These work the exact same way for that. And what Megan's doing is she's just your pedal right here will change the settings for these devices.
All right, for the sew-in here, the blue is for bone. And the pink flash purple is for your traditional infiltration or local. So when we were initially bringing on these devices, there were times that I would start and try and find bone, test my limits on maybe the more teenager patients that I wasn't comfortable with. And if I couldn't get it in, then switch it to that pink and then go into your vestibule and deliver a traditional. Try not to set this device down. If you are committed to it, try not to set it down and pick up your traditional syringe, because then you're only going to get comfortable with what you're used to. So the difference of the Soin versus the sleeper one is that the Soin has these resistance indicators here. One is fine, you're go for launch. 2 is my personal favorite. That tells me that, hey, I'm in some good bone and it is delivering good intraosseous. But you don't need a 2, okay? 1, you can still be in good bone. But I like the little reminder that I'm there. 3, you're getting pressure buildup. Too much resistance is forming. So maybe you have to wiggle it out and reverse it a little bit to get back down to that 2. But it will still deliver fine on the 3. 4 is when you're going to see the slowdown of your plunger. The great things about these devices is they have a fail-safe. They will not over-deliver that anesthetic into an area that has too much resistance. If you are on a place that is saying Mayday, Mayday 4, it is going to stop. It's going to retract that plunger. You're not going to be able to over-deliver that anesthetic there. And then with the Sleeper 1.5, you have the circumferential light. That's the indicator. And when you are delivering it, it is going to blink. And it actually pulsates and blinks faster when you have more resistance.
So let's talk about what Megan was saying about when you get to those 3 lights. So why possibly could you have 3 lights? Either you are pressed way too up on bone, or you're in some really thick, dense bone, and the anesthetic cannot flow properly from the end of the lumen of the needle. Or the third thing that could be happening is you have a bone spicule somewhere stuck in your lumen of the needle. Those are the 3 most likely things that are causing the lights to react like that. And like Megan said, you want to pull it back some. You don't want to pull it all the way back out, because now you've got to mess with the integrity of the needle tip again to go find more good bone to dip into. The other thing we really don't want you to do is take your foot off the pedal. Every time you take your foot off the pedal, it's going to start back over and slowly start delivering anesthetic again, and then start to tick back up. So you're just making it take longer. If you do that, the best thing to do is to try to just like pull back a little bit without pulling it all the way back, right?
Yep. Yep. All right. So with these devices, you do not need to use your topical, but as a new user, we highly recommend it, because you don't want to get in your head of, is it the device? Is it, I'm switching up my routine? So still using that topical until you master all of this. The other thing that can help is using your section or a dry shield. Love dry shields for delivery. 1, it takes the taste of it away, but it also opens your patient at the appropriate amount for you to get a good access point, especially if you are trying to learn how to go on the palatal or the lingual. I love having the dry shield in when I'm accessing the palatal or the lingual, because I feel like the tongue's out of the way, the patient is nice and open, I can move them around, and they're not going to taste any of that anesthetic because it's sucking it all up. The other thing you can do is place a 2x2 or a cotton roll in that area to try and get some of the anesthetic. When you're trying a new technique, you're going to have dribbles, because you might be over delivering on stage 1, or you might not be fully in bone and engaged for that phase 2. So you're figuring out the use of the pedal and the device. So you want to try and keep anything bad taste away from your patient, because you might lose them on just that. For an advanced user, it's your personal choice. You need to figure out the patient in front of you. Remember, we're looking at our patients as a whole. You're not just looking at their tooth. You need to look at their anxiety level, their behavior that was at the last appointment, all the things. Is he white knuckle in the chair already? You might want to still use that topical, because if you're like us and have parents that watch through the window, or parents in the room, and they lose it for a Q-tip going in their mouth for topical, you might be like, hey, Mom, it's not my cool new device that I'm using. It's your kid acting a fool. Suction or gauze or the dry shield, should still be utilized to take away that nasty taste of the Septicane Articaine. It does taste a lot more bitter than lidocaine does.
And we're going to spend 0.3 seconds on organic chemistry tonight so we don't vomit. But what Megan was saying is these devices, any intraosseous, not just these devices, but anytime you're giving an intraosseous injection, it should be with articaine, which is Septicane. And it does have a different chemical structure than lidocaine does. Lidocaine is I grew up on lidocaine. They were the first to market, and they've just stayed tried and true in the market. But really, Septicane is the gold standard for intraosseous injections. It does, and the reason for that is because it has this different structure. This is more than 0.3 seconds. However, it's going to enter into the bone, diffuse into the bone a lot better. And that's why we recommend using it. The number one reason. These are also some really great reasons, different half-life, better half-life. And it's really nice to see that it's metabolized in the blood instead of the liver. Lidocaine, we don't need to be, wait till you're an adult to ruin your liver. Don't ruin it in these kids, please. We showed this earlier, but 1 to 200 is pretty much the gold standard with these devices. It gives you about 30 to 45 minutes of working time. If you do feel like you need more working time than that, you can switch out to 1 to 100,000 if you want to. It will give you more working time. But we've just found that let's say that you're using 1 to 200,000 and it is a longer case. You're doing some stainless steel crowns on hypoplastic molars, or it's a really good kid and you're getting 2 and 3 quadrants done and you're going to push the limit of time, you can just inject again. So we really prefer to stick with the 1 to 200,000.
Or only do the 1 quadrant first and then deliver it again on the 2nd quadrant when you're done with the 1st quadrant and you're not having to inject again. You're just having to pick up the device again.
Right. This was just a cool tip from Josh because it is sometimes hard to see what's a quarter carpule, what's a half carpule. And so he puts these little rings. He uses the rings differently. He puts them on there so he can tell when he sees the gray plunger past the quarter and the half and the 3/4 mark line. So this is the one thing we hear, why does it go so slow? And we would definitely encourage you to, like anything in your practice, you have to educate your families about this. Dr. Laurie Johnson, she had a dad go off because he couldn't understand why she was jabbing a needle in the patient's mouth for so long. Yes, it is a longer injection than you would probably give with a traditional syringe. So you want to prepare your families for that. And also, once you master it and you're not using it topical anymore, a parent's going to say, well, my dentist gives me topical. Why doesn't my, sweet little Susie get topical? So let's talk about why it goes so slow.
So we talked about you think you're manually delivering a good a good slow cadence of your traditional syringe, but you're always going to deliver a little push, a little bolus. This is delivering it slow and steady as it ramps up to those delivery speeds that you set it at. And it is about 1 ml per minute. So a whole cartridge would be about roughly 2 minutes. So it's really not incredible amount of time, but it is like watching paint dry when you're first using it.
But the cool part is if you're just doing an MO and a DO in 1 quadrant,
you're not using a full carpule. Yeah.
Right.
So we are about a quarter carpule for any traditional MO DOs, class 2s, class 3s, whatever, any composites. I would say I go about a quarter to a half for pulps and crowns, or things that I might be digging around in the gums line for. And hot teeth, you might be more to that half to 3/4, depending on where you get good bone to access, especially if it's an abscess tooth. You might have to be further from the target, so you might have to deliver a little bit more volume for that. So here we go, but it goes so slow. So this is me with a little guy. He's either 3 or 4. This is a fully sped up video here. I like to have you look at this guy's eyes. He is just hanging out, chilling with us. He's about to get a facial on G and some extractions of E and F. His hat has not moved an inch. So if you know any 3-year-olds, I know my 4-year-old does not sit this still for normal things. He did not when I tried to do a filling on him. So I appreciate this little guy sitting so still. But there's really no facial reactions there. You can see behind me a little bit as this camera comes up that mom might be hanging out at the window. She might not be doing anything at that window. But here we are. We're doing the filling. Assistants coming with some air and water, scooping out some extra decay, making sure it's good, coming in with the etch and bond, all the fun things. See, there's mom on her phone back there. She's not caring at all that we use the sew-in. And but that's one of our things. We educate on the front end. You always want to educate on the front end. So if it does, we do have a patient that goes south on, you're not the bad guy because you've always talked about this new device that you brought on. So here we are polishing up this filling. My assistant handed me some rongeurs. We are getting these 2 bad boys out in the front. And there he is. So not white knuckle in the chair, no, a little thumbs up at the end. And that was 7.5 minutes, guys. I was able to get up after that, go check some recalls, maybe even work in some same day treatment, and get that kid back to his mom versus waiting in, why am I in this strange room with this woman and what's she going to do next? It's always that anticipation of kids that don't know what's going to go on next. Great thing to look at with this intraosseous is these extraction sites. It gives incredible hemostasis. Nothing is gunky in there. Nothing is spewing out. We don't really have patients walking out with mouths full of gauze anymore. 1, because we're not worried about them chewing up their cheeks or their lips. And 2, that hemostasis on these extraction sites is so amazing.
So here's another case. This was one that Dr. Nash did. This was actually his first permanent tooth extraction. So because he was a little nervous about it, he's going to give stage 1 and stage 2 on both sides of this tooth because he wants to be 100% sure. You don't have to do that. He was just a little nervous and intimidated that he was going to be doing it with this kid.
And this is the great way to get your training wheels off. Get out of your head, over deliver some anesthetic at first so you're not worried about, did I do it right?
Were they numb?
Yeah, were they numb? And then learn your comfort zones and start pulling back. So here we are, this man, 2 thumbs up, 6 minutes and 51 seconds.
Like we're at the rodeo. You got him.
Who else would give a traditional local and even sit back down in that time? Nobody.
Right.
Bueller.
You'll be waiting on it. This is another sad little friend of ours. It's tough, these little ones. We don't have a lot of tools in our toolbox, oral conscious sedation, IV sedation. Not what we're wanting to do, but we want to get this kid out of pain and we got to get a tooth out of here. So super sad, but super compassionate and super fast.
This was probably these anterior extractions, these D through G hold and goes was the selling point for me. Because who likes to get up out of that chair when your heart is thumping after giving these kids injections, knowing that they're now hugging or crying on mom or waiting for that anesthetic to soak in. And then they're feeling this lip being numb and not comprehending that. And now you're having to lay them on back again and take these teeth out. This little guy wasn't loving the procedure from the get-go, but mom was a great hand holder there for us. And 2 minutes and 5 seconds.
The other thing I think about for these anterior cases, when you're giving traditional injections and you're up doing those infiltrations, how bloody that is when you're giving those injections and then there's blood everywhere and the kid's crying and it looks like a horror. I mean, it's so much worse than it has to be.
So here was one of our latest cases. One that we went back and forth on with our local orthodontist was extractions of 7 through 10, or 7 and 10, not 7 through 10. Lord, we would have said no for that. 7 and 10. So sadly that number 6 came in and destroyed some of the root on number 7. They took a cone beam so we could really evaluate all of our treatment options. They were presented with about 3 options, to take one lateral, to take both laterals, to do canine substitution, all of these things. And they did opt for removing 7 and 10. So this young woman, if I had some easier, better tools, we'd be looking at not damaging those canines. And that's what I kept slipping, trying to make sure I wasn't knocking anything. So if I was quicker at some crowded extractions, this might have went in even easier. But you can see she is hanging out there, looking good. 6 minutes and 58 seconds for these 2 guys. And these are the roots. So that 7 was definitely destroyed by that canine. 10 looked a little bit better, but it did already have some apex destruction. And those are those extraction sites, that hemostasis right after the procedure. What I want you to see in these other 2 little stills of this is that awesome blanching that you can see. You're not going to see this in all patients, depending on their cultural demographic or their hygiene. Sometimes it's just such poor hygiene that you get the initial blanching underneath, but you still have that rosy red on top. Another great indicator is when you see that palatal blanching going on. But again, it's not happening on all patients. So just if you're in your head about it, take your Explorer, take your periosteal and start digging in on the palatal so you know that they're numb. You don't always see that blanching occur.
This was just that little girl. This was actually Josh's patient, and he was just saying that how he just gave was able to give 1 injection, and he was able to get all 4 of those teeth out with 1 injection, whereas before he'd have been stabbing and playing around in that whole anterior section. Right there is where he went.
So we need to make sure that we are in the right little target point. The purpose of this intraosseous injection is getting into the bone, to letting that septicane diffuse through these Haversian and Volkmann canals. If you are not into this porous bone to where you're having these canals, it cannot travel from the buccal to the lingual. So you might be in an area that might have too dense of bone, and you might need to reorient a little bit, or you might be in a PDL, sadly, as you're learning to give these injections, and it's not going to be able to travel through. So our traditional local infiltration, again, you have to go from the tissue with the diffusion from the soft tissue to the bone, to hopefully around the nerve of your tooth. And we're doing those regional blocks. This, with the intraosseous, you are really going through the bone, getting into these Haversian and Volkmann canals, and traveling to the target, which is the apex of your tooth. And that's why we're not having like a whole side of a face numb with all of these, because you're not doing a regional block of that nerve.
Mm-hmm. So here's some of the mastering right here, right? Because it is, the further back you go posterior, the harder it is to get the angulation and get stage 1 and stage 2 in certain areas on certain patients without standing up and moving around. And sometimes it's a bone issue. Sometimes you just have better bone on the lingual. I'll let Megan speak to this because this is her jam.
I love going from the palatal to the lingual. I'm a weirdo. So if you're a right-handed provider, I feel like the upper left is the hardest access point. You feel like you're awkward getting up there with the device. One key reminder is your patient can move. Even if they have a nitrous nose on, you can either move them to the side so you can get better access from the buccal. But say you have a large paralus, you don't have that good bone. Remember, you have great palatal bone most likely. So going from your palatal access, you're still laying that device. Try and do it horizontal for your phase 1. Why you need to be careful with your vertical is you're more likely to jab and stab it in there because you have that just puffy papilla, and then you're going in and you're hitting that periosteum already. So laying it flat and vertical, letting that needle flex a little bit before advancing. And then reorient and come now vertical for your phase 2 and get that good palatal access. Another great way, if you're a right-handed provider, is on K and L, or this lower left quadrant. Who doesn't get those big gnarly abscesses on a first molar that you looked at the wrong way? Because they like to abscess on us. So going from that lingual, getting your dry shield in there, so you already have the tongue mangled and taken care of, and then laying that for that phase 1, just reorienting this way for that phase 2. It's a great delivery, and it's my jam. So if you haven't tried it yet and you already own the device, try it this week.
Yes, it works. And no, it does not hurt more. And don't be a baby about it.
Because it's my jam.
Yes. And she already said it's great when you've got some nastiness going on the buccal.
So here is a gnarly looking T with a sinus tract and a buccal perilous there. You could, if you have great bone, go from that lingual. But here we're going from that, I think they went mesial and distal on this to try and find good bone. I do believe there is a little bit better bone on that mesial. But remember, you have a patient in front of you and a 2D x-ray to look at. So use all of your senses while you're finding these spots.
Right. So again, just showing, this is Dr. Paul Bond's patient. He's just showing that going from the lingual is something that you can try before you set your device down and get your traditional syringe out. Again, just showing going from that lingual. This, if you're in, I mean, I've seen this pop up on IPEDO. I've also seen this in the SOIN Facebook group as well. This is a concern. We've seen pictures of it, and this was one that was reported. And we can kind of talk about a couple different things it could be. It could be that you over-delivered in stage 1, and now you've really irritated that tissue. It could be you were down into the periosteum and you've really irritated some tissue. It could be you delivered way too much anesthetic and it just couldn't handle it and it necrosed the tissue. The patient could have been picking at it afterwards.
That area is numb.
It is numb. They could have been picking at it.
Or you're having the training wheels coming off and you're trying to stab a couple times to find that good bone to deliver.
Right. We kind of already talked about this. Megan mentioned how you want to go in from the side and sort of try to gauge where your needle needs to come in so it hits the middle of that triangle. All right, this is our third pearl. We're all into merch. We love to make families, and you should do it as well. You should do something different. All your patients should experience something different in your practice that is good, especially as a new patient, so that they're like, wow, this is really worth coming here. So this was a huge hit. Jeanette McLean turned us on to these. She does it in her practice. All new patients get these magnets, and we put the kids' pictures in them. And then we also run a tongue tie and airway center here. So we have these cute little onesies that we have made for the infants when they get their tongue ties released here in our practice.
All right, so what is the difference between cruise and drive? Cruise and drive is only on the SOIN. It is not on the Sleeper 1.5. So that's what Dr. Ann was saying earlier. This is the
Dummy proof.
Dummy proof. You're going to push the pedal. It's going to deliver. When your foot comes off the pedal, it's going to stop. The cruise and drive is just like when you're in the car. Cruise, you're going to touch it, and the car drives itself, right? You're going the same speed. Drive means your foot needs to stay on that pedal for it to deliver that anesthetic. So here we go. Foot on the pedal versus setting and forgetting. How do we know we're in cruise? And this is why I like my Sleeper 1.5 more than my SOIN, because some fools over here like the cruise control and I like the drive. So I set it down and you're busy talking to your patient and working, already getting to work, while your SOIN is still blinking because it's still delivering anesthetic. Then you look over because you might want to try and add another quadrant in or whatever, and your plunger's already back and your lid is full of anesthetic because it was in cruise control and you just took your foot off the pedal thinking you were in drive and it dumped the rest of the carpule there. On that last slide, it said, why am I in drive, but it only delivers a quarter carpule? That is because you've also messed with the settings on the SOIN, and the SOIN has a inside setting where it can deliver a quarter, a half, 3/4, or a full carpule. So again, read the manual first because it happens.
Yeah, your assistant, somebody's going to touch something or push something and it's going to get out of whack from what you like. what default you want it to be, and you need to know how to fix that.
So we'll add another pearl into here is if you own the sew-in, or if you're thinking about purchasing the sew-in and you're going to do your training, only teach yourself and your team members to retract the plunger with this pedal here. This will retract the plunger. On the sew-in, there's also a button here that retracts the plunger, but if you hold it too much, you're going into the settings, and that's how our settings get mixed up from what we personally like.
So again, you want to not have any surprises with your patients and your parents. So you want to tell them, describe it like you're using a digital pump, or it looks like you're taking somebody's temperature. And you need your parents prepared that you're going to be starting treatment right away, right? Because their initial reaction is going to be like, she's not numb yet. What are you doing? Again, you can eat and drink right away. You need to relay that to your parents. NuSmile makes these awesome brochures that you can hand out ahead of time or afterwards that talks about the benefits of using these devices. And they're also a great referral to your GPs. You can let them know that you're using these devices. We actually have signs outside of every treatment room that describes the benefits of using these devices. I'm going to show it to you. QR codes are handy for all these handouts that you have. I already said you can talk about like it's a magic wand or you're taking the temperature. This is what we have hanging outside of every single room so that parents understand that we are numbing their kid using cool electronic stuff and why we're doing it.
So another great thing to set yourself apart from other offices in the area is highlighting this on social media, because you might have a mom scrolling some social for the day. They get interested in your office, thinking about going there, and then they're starting to look at what you guys offer. This is a great, cool way to get your maybe potential new patients intrigued. This is one video we did on our Instagram.
Let me tell you.
And that was the caption up above. And this mom commented on it. A wonderful comment that highlights how great the devices are. And no, I did not drop the sew-in from that high above. We're going to talk about the warranty here in a minute, but there was a very big cushion for it to fall into. It would not be covered under the warranties of dropping it for a social media post.
So we kind of touched on this, but why could your patient be having discomfort? Well, maybe you just ripped out 2 rotten teeth and did a couple fillings, right? So if you're calling and checking on your patient and they're sore later, don't go back into thinking in your head, like Megan said, don't overthink it. You probably did a lot of dentistry on the kid. That can be one of the number one things. The other thing is they're not numb as long. So they may not be checking out of your office. They may be just getting up front and all of a sudden they're starting to have that feeling come back. And now they're realizing like, dang, you just did some major dentistry in their mouth. And we talked about this too. When you're getting your learning curve there, you may be stabbing these people multiple times trying to get it all figured out. And the worst thing is you're probably in the PDL, and that patient is definitely going to be sore when this is all said and done.
But if you are in the PDL, you're probably going to get a facial response from most of your patients because they feel a little bit more pressure build up there.
These are Josh Solomon's 4 Ps, which are really handy to know. Check the power. Make sure the device is on. Make sure you leave it in the charger. Someone needs to be kept in a charger. You're going to get lots of usages out of it throughout the day. And plan. Make sure you've looked at your radiographs. Make sure you decide ahead of time where you're going to inject, how much you're going to inject. Does your assistant have the suction handy? Review all the things with the parent. This is a big one. Make sure you know where the pedal is. You don't want to have your needle ready to go into tissue and you have to look down and find the pedal. By the time you look back up, your needle is not where you probably initially wanted to put it. And then is everyone in the right position? The doctor, the patient, and your foot. So some key tips that helped us make the switch to electric anesthesia is this is making us money is what this is doing. By doing more same day treatment, I mean, we looked at it for a while there and we were doing
we were working in probably
4 to 5 at least treatments a day. that we could do. I mean, now we have a team that hustles and we have doctors that want to help kids and families, but I mean, if you want to go to the golf course sooner, you could do that too, but we're able to do a lot more same day treatment. Especially those kids that come in and it's something super fast, right? They're out of your recall pool and you're like, oh my God, it's just a little tiny occlusal on such and such. Like we can get it in so much faster. All right, well, let's talk about what they cost. This is the going rate right now. I will tell you in the 2 years that we've been using the devices, the price is not going down. It's going up. It's continuing to go up. Everything's going up, right? Gloves aren't going down. They're going up. If you buy more units, there is a better price available to you. And like we said earlier, the Sleeper 1.5 is a little less money. And we call it the 1.5 because it's in its 5th generation. It's been around a lot longer and they've worked a lot harder to get it to the 5th evolution, whereas the Soin, it's the 1st evolution. All right, kicking it to you guys.
Yeah, so we're doing $500 off for all webinar attendees, which all of you are. So this is good through the 30th. If you guys are interested in, I'm sorry, you guys does not sound natural to me. I say y'all. If y'all are interested, please reach out to me or Chris or Aaron directly. You can also call into customer service line, which is there at the bottom. So if you're interested in getting another unit or for your first unit, now's the time to do it before the end of the month because we're doing $500 off.
And I'll add too that is better pricing, better discounts, the biggest discount we've ever offered. It's better discount than the 3-unit bundle price. So just buy 1 unit and you're getting a better discount if you buy 3.
And these are the prices for the needles now. They come in 3 different gauges and lengths. And just to tell you that these proprietary needles, you're probably spending 11 cents per needle now with whatever box dental company you're using. And these are about 27 cents a piece. So definitely worth it. It's the only, that and a carpal vein aesthetic are your only expendables. Jordan, you want to talk about these?
Yeah, so we have a new warranty plan as well that we had just launched. Just about a week ago. So basically your device comes standard in a 2-year manufacturer's warranty. What that covers is anything that were to go wrong with the device that had no sort of user input. So, some sort of battery issue or anything else along the line. So that's good for 2 years. That comes standard with all units, Soin or Sleeper 1. You can extend the basic warranty, the manufacturer's warranty, for $399 a year or $299 depending on your device. All warranties must be purchased within 30 days of buying a unit. So if you want to, if you know you're going to want to extend the warranty, well, then you can go ahead and sign up to extend the basic warranty. But we also have a couple of different packages. So if you want to go to the next slide. So we have the Care Pack. I'll let you read the description, but essentially what this is going to cover is this is going to anything accidental. So pretty much no questions asked. If you have, you drop it, something goes on, you damage it, crack it, anything like that, you're covered there. So that coverage starts at, the time of purchase. So it'll take over for that manufacturer's warranty. You'll get priority support. And then if you want, you can pay an additional fee to get a loaner that'll come to you. You also get a maintenance. So maintenance is basically where you can send it in once a year, have it checked out, kind of under the hood. That's all complimentary with that as well. And then the last one we have is the Care Pack Plus, which is the exact same thing as the Care Pack. And then, but you get free rush shipping. You also get a loaner device covered with it. So if you guys have any issues or anything like that, this is like the white glove service where you are, okay, I need this taken care of like today and tomorrow you're good kind of thing. So, and that's it for the new warranty packages.
Thank you. That's really helpful because we're coming up on our 2 years and obviously we're not going to get the warranties because we've had them longer than 30 days, but you should.
For all you other people.
Yes, all you other people that they like better than us, you should get that.
This is probably a good time to mention for all legacy customers. Chris, do you want to talk about that? If you've.
Yeah. So anybody that has a device, the manufacturer is covering a lot of those subtext that's part of the different warranty plans. So those are kind of grandfathered in with the manufacturer, with Dental High Tech launching these warranty plans. We're getting to a point now where these units have on paper, they have a life typically of about 5 to 7 years, and it's just added protection. So from Dental High Tech's perspective, from NuSmile's perspective, we just want to make sure that everybody is covered and protected. And with the launch of these warranty plans from the manufacturer, we've worked out a deal with Dental High Tech to where anybody that was an early adopter to these products, they are grandfathered in for that legacy package where no questions asked, everything is covered.
Very nice. Very nice. All right. So speaking of money, we just really encourage everybody on this call tonight. I think there was over 60% of you that don't have a device yet. We really want to see you get a device. This is being taught in residency programs. I don't even know how many residency programs y'all have trained in by this point, but Chris, I mean, it's a lot. And you're on airplanes every week, going to more residencies, and these new grads are going to come out, and that's what they're going to know how to use and want to use.
Yep.
Advice we can give you is to be patient and to practice. Like Megan said, don't have any syringes in the drawers. Don't let your assistant bail you out. Just be patient, practice going into the bone, practice on your assistants, practice on good young patients, practice on kids that are under sedation, and just keep practicing and be very patient with it, and the learning curve will come quicker.
Join the Facebook group. There's never a dumb question there. Everybody that is a KOL or a NuSmile team member is ready to reach out and give advice and help out. One of the best things you can do is take a video or a picture of things going on. I was just texting Chris and Jordan about a colleague that was having an issue with his, and he was like describing it to me. I had no clue. I was like, take a video, but he wasn't at the office. It wasn't happening anymore, and they walked me through it. So I'm still learning even after using these devices for 2+ years. But best thing to see your technique is have an assistant or a team member recording you do it. You might play it back to yourself and be like, oh, I see what I'm doing wrong when you see yourself, or send it to the Facebook group. And don't be anonymous. We all learn from each other. So.
Training, like we said, lots of great training. Chris is on this call tonight. So is Jordan. Take a screenshot. This is their direct cell phone numbers, and this is their email addresses. You can reach out at any time. They will help you with anything. And then Erin, who is not with us tonight, she is putting kids to bed. She's a trainer as well. So please screenshot their information and reach out to them. They're always happy to help. Lots of trainings available. Like Megan said, we've trained pretty much everywhere. Everyone here in Greenville, we pretty much all have a device, and some of us have more than one, and lots of hands-on training. That's one great thing about NuSmile. They don't just launch a product and let you try to figure it out. Lots of great training available all around the country in lots of different conferences and settings. And you know the solution to all your problems, but you just don't want to do them. I'm telling you, this is a solution to lots of your problems. Kids' chewed up faces, dentistry taking longer than it should, bloody extraction sites, hypoplastic teeth that you can't get numb after 3 carpules, and you send them home and tell them to come back another day. So this is a solution.
I tell this to a lot of people, but I know she's an early adopter. She's constantly thinking 10 steps ahead. So when she came back from Bourbon and Baby Teeth that year, she was on this huge high, and she's like, okay, with your permission, I'm going to ask if we can get somebody from NuSmile to come here and show you, because none of you were there. And I was like, they're going to come, and the next day I'm going to go back to my normal ways. And here we are 2 years later. So take it from the person that was I know my solutions and I'm not going to do them, to the person that is dragging you towards them. Sometimes you just got to trust somebody else's gut besides yours.
True. And don't overthink it. We've said that 100 times on this. Just don't overthink it. Just try it. You remember you had to use a traditional syringe when you were 20 something years old learning this in dental school. You can do this. Don't reinvent the wheel. There's so many of us out there using these devices now. There's a world full of people ready to help you. And Megan said, make a video. That is the best way we can help you. If you're just like, well, it's this angle and a lot of stuff's squirting out, I'm like, no, you've got to send us a video. We're going to skip through this because we're chatted a good bit. These are all the people. You may notice somebody or a lot of somebody's on here, but these are the lead key opinion leaders with NuSmile and working with Dental High Tech to help you with these devices. We're all around the country and around the world, and we're here to help you.
And this is my little plug of social proof here. So this is Dr. Bobby Lunka. He came to the restore that Anna and I were at in Charleston. He said, I have the sewing at home and I'm not confident on it. So I've tucked it back away. I haven't looked at it. And we were like, what are you not confident in? We did our hands-on portion and he said, if you guys would have me, can I please come to your office? And then he went home. And then the next day he said, are you guys serious about hosting me at your office? And we're like, absolutely, come on down. So he came to our office on September 11th. And this was me checking in on him last week to making sure that he committed, just like we committed to taking him under our wing. So he practiced it for 2 days in general anesthesia. And then I checked in on him today and he has used it more successfully and confidently on a live and awake patients, and he has told me he will tuck away his traditional syringe for a little while and get more comfortable with it. So we encourage you to reach out to us and we will help push you like she pushed me.
Come to our practice. I mean, it really is a great place to learn. We have 2 to 3 doctors every single day using the devices. So, and we each do 10 to 12 ops a day at least. So, I mean, if you were here with us, you would get to see and learn a lot.
Other options to learn and see a lot is the restores. There are 4 big restores coming up through the end of 2025 and the beginning of 2026. I know spots are getting limited in Newburgh and Fort Lauderdale. So if you're interested in any of those locations, please reach out to NuSmile and these guys right here. And then they are, as Chris said, they have heard the feedback. They have heard that you want more hands-on training for certain devices, including the scanner and the sew-in and the Sleeper One. So they are doing a 1-day course. Chris, you want to talk about this more?
Yeah, absolutely. So it's no fluff, right? No fluff, hands-on course. Really going to set the curriculum to have it be super hands-on, different kind of case presentation. We're actually encouraging upon registration to submit your own cases. So you can submit x-rays and different kind of treatment plans, and we can actually go over all of those cases with everybody at the workshop. It is a full day. It's 11 to 5. It's conveniently located at the Marriott Hotel that is attached to the airport here in Houston. So you get to come to Houston. NuSmile headquarters are here. We'll have that course going on. Super easy to get to. Don't even have to leave the airport, essentially. Come in, learn a lot, leave with just being super comfortable, whether you're brand new, don't even own a device yet, or have had the device for 2 years and are just looking for additional hands-on training. The 3 gentlemen that will be leading that, Dr. Josh Solomon will be leading that course with Dr. Patrick Ruck and Dr. Paul Bond. Both are academics. Dr. Patrick Ruck is at Cincinnati. Dr. Paul Bond is at Temple. So they have a lot of experience with training over the shoulder with their residents. So they're going to bring that expertise to the event. And then Dr. Josh Solomon is a super early adopter with a lot of different technology, but really went gangbusters with the SOAN and Sleeper One. And to quote him, this should be the standard of care for pediatric dentistry. So hopefully everybody on this call will attend. If not, we'll definitely be doing these again next year. Schedule hasn't been announced for next year, but we're planning on doing these full day, no fluff, just hands-on workshops at least once a quarter, conveniently located again in Houston. So hope to see everybody there.
Well, we just want to thank you guys for spending your what is this, Wednesday night with us, Hump Day Wednesday night with us, and thank you. And this is my contact information on that.
How we say it all the time.
Yes. Thank you guys. Seriously, it is, to Josh's point, this is going to be the standard of care. I will hang my hat on that.
Awesome. Thanks, everybody.
Thank you. Well, hold on, but before you jump that time, like that was a farewell. Before you all jump off, you have questions. So if y'all want to,
we do have questions. We do have questions. We got some good ones.
Okay.
Again, just everybody, just to reiterate, Q&A feature at the bottom. Chat's not live, so just use that Q&A feature to ask questions, and we'll get started with a few of them. We'll answer as many as we can. First one: How do you schedule 30-minute operative appointments? Is that 30 minutes of doctor time and more time is allowed for DA to prep the patient, go over post-op instructions, flip the room, etc.?
Yes, we schedule in 30-minute blocks, and the doctor time is like Megan showed in the videos. For those treatments, we're in there 5 to 10 minutes, 15 minutes tops sometimes. But yes, the assistant's bringing the patient into the room, pre-oping mom and getting verbal consent, getting the parent situated at the window, calling us into the room, and then turning the room over and getting it ready for the next patient, doing all the notes and everything. And also we run in our practice, we run 30-minute ops, and we're all checking in those 30-minute op windows. We're all checking 4 to 6 recalls in that 30 minutes also.
But we do have at least one extra treatment room as kind of like an overflow. So if one is taking some time, that's where we get a little bit of our wiggle room from.
Yeah.
Awesome.
Good question.
Thank you. Are you able to use the SOAN for profound anesthesia on lower permanent second molar restorations?
Depends on the patient in front of you. The SOAN is approved for 14 and under. You definitely can push those limits. I say try it first. I have some patients that surprise me. It's usually the bigger, bulkier kids that you're like, hey, he already has dense bone of a 25-year-old man. But sometimes that device just sinks right in. If you can find that sweet spot, you're gonna get great access and great anesthetic there. You might have to deliver a little bit larger of a volume right there, especially sometimes with getting the good access. You might have to deliver a half a carpule, and you're not doing a quarter carpule for a traditional class 2. But you can definitely get them nice and numb.
And you have the lingual too.
You have the lingual.
Next question is, what is the difference between the SOAN and other anesthesia delivery systems on the market, like the Woodpecker Star Pen and the Wand?
So Chris, do you want to take the question? Do you want us to take it?
I can absolutely take it, and then I would love, because I know you guys have used both before, especially you, Megan. You were all.
I used the 4-letter word in residency.
Yeah. So the SOAN and Sleeper One are electronic assisted anesthesia delivery devices, just like the Woodpecker, just like the Wand. But the SOAN and the Sleeper One are the only ones indicated and approved for intraosseous injections. So all the other electronic assisted anesthetic devices on the market, they're great devices. They do what they're supposed to do, but they are single tooth infiltration PDL type devices. You cannot do intraosseous injections with them. That is going off label. If you actually read through the IFUs for those devices, they specifically say not to use it for anything besides a PDL or infiltration type injection.
Boom.
And then I had experience with the Wand in my residency program. So again, when she brought up this forward thinking and early adopter, I was like, oh, not again. I'm fine with my traditional syringe. I would say one of the best things I love about the SOAN and the Sleeper One is the proprietary needle of the Epitech needle. You're giving that pain-free, painless phase 1, stage 1, and then it is so nice and sharp that if you are getting comfortable with that stage 1, you're able to penetrate there and get that intraosseous that it is approved for.
Awesome. Thank you. Next question is, how long does it take the papilla to heal after over delivery of anesthesia?
That would be like any typical pizza burn in the mouth. I like to say about 5 to 7 days, but it really depends on the patient in front of you, their healing time, their health status, on how fast their body can flip over that tissue. But typically, if we see ulcerations or lacerations in the mouth, that is what we're telling the parents, because we know that mucosa does flip over and heal faster. But you do have to look at all the other variables of that patient in front of you.
Awesome. Thank you. Next question is, can you go over phase 1, stage 1 again, please?
So for stage 1, you are going to take your sew-in or your sleeper 1. You have a D labeled on your needle. That is showing you where the bevel is of that needle. For this phase 1, you are going to slowly lay it on the papilla, get a little flexure there, and then slowly advance it so it is underneath that papilla. You're barely getting that bevel down to give that phase 1. And then for that, it is the center pedal on either device, and that is giving a slow drop by drop anesthetic delivery.
Awesome. Thank you.
Nothing else. That's perfect.
Anything to add? Good. All right. We did have a question about resident training. So for a specific school here. So I'll just kind of talk about that real quick. I know Ann and Megan talked about study clubs and doing those kind of group settings. Absolutely love to do that. If you can get a group of 30 to 40 doctors for your study club, I'm happy to come and do some training with you and your colleagues. For residency program
in Hawaii, we're happy. We will gladly take one for the team and do that.
Right. And if it's not, we send Jordan.
Yeah. Well, yeah. So this one's in Nebraska.
So for residency programs, like Ann and Megan said, huge proponent for doing the residency programs. Most of my time over the last year and a half has been going to different residency programs and working with the faculty, most importantly, working with the faculty, and then training the faculty and training the residents to then continue to train the residents. So have your contact info here. We'll make sure we share my contact info again. And if you wouldn't mind putting that slide up real quick. So reach out if you are involved in residency programs. Happy to talk to you about scheduling that. Absolutely looking at dates for 2026. 2025 is kind of out of the question at this point. But for 2026, happy to discuss that with you and just put something on the books. All right. Next question is, any risk of injury to developing, I'm not going to try to pronounce that word, developing tooth bud while using sew-in on younger patients?
Get this question a lot, and it is, if you're thinking right, it's a good question to ask, but it's like any injection you give, you have to know your anatomy. And also, we're talking about a 9mm needle here. This needle is, if you're near a developing tooth bud, you are not using the device the way that the training and the manual and all of us are teaching you to use it. So that we can't think of a time or a reason that you would be near a developing tooth bud.
As you're entering for that stage 2 injection, right? You're shooting for that tip of that papilla. So as you're coming almost in between the two teeth, you're really not going to, even if you delivered that needle up to the hub, you're not going to reach that far down.
Right. You've got a much higher chance of being in a PDL than being in a developing tooth bud.
Correct.
I love that question in particular. I was just going to ask, can the doctors, Megan and Ann, can y'all please say that word for Chris and I?
We don't have the questions up. We're going in blindly.
Oh, gotcha.
Thanks. This is why we're not dentists.
Exactly right.
I don't even know where it is.
I don't know either.
Another question here. What material do you use to show patients and parents? What material do you use to show patients and parents that you're using sew-in so they can read about it?
The NuSmile brochures are great. We have the assistants give a brief overview before the patient goes into the room for the treatment, since the parents aren't in there. And then I showed we have these little signs that hang at the door or at the window where the parents are standing, so they can understand they're numb right away. It's delivered electronically. It takes a little bit longer to go in. It's more compassionate.
I definitely think we get a lot less questions from parents because it has been the standard of care at our office for 2 years now. So we're seeing it less. But the new patients that come in, I mean, the parents will say, but you're going to give them a shot, or, you know, that dirty 4-letter word. And that's when we, again, educate on the front end. So you're not having those questions pop up while you're mid-treatment about what is that? Focus on the patient in front of you. Nobody's really asked for literature on it, but you could always send them to the NuSmile website or the webinars if they really want to deep dive in it. But I think just a pamphlet, a brochure would be fine.
Yeah, I mean, just like with all the other NuSmile products too, I'll kind of piggyback on that. You know, we actually do get a lot of phone calls at NuSmile about other products, you know, crowns, neoputty, cements, anything like that. Parents do inquire about that. So if you do have any parents that are asking for more detailed information, definitely let us know. Happy to share information with them or go over and answer any questions that they have.
And this is standard of care. These devices have been around in other countries for 20 plus years. Not these specific devices, but intraosseous electronic anesthesia devices.